Good afternoon, everyone, and apologies for the late starting of the session. We had some technical issues, so very much apologies to, first of all, the speaker, Dr. David Shelton in particular, just some technical issues getting his presentation across, but also to yourselves, and thank you very much for your patience. I hope at least some of you, as many as possible, are still on the line. Just very quickly then, so that we don't lose any more time, this session on salivary gland cytopathology is being given by Dr. Noreen Akhtar and Dr. David Shelton. They are both consultant cytopathologists at Manchester Cytology Centre and have been my colleagues for several years, particularly Dr. David Shelton, who I've known for, I don't know, at least 15 years. They're very busy. It's a very busy tertiary cytology centre, so very grateful for their expert advice in this very important area. Now, David Shelton, Dr. Shelton has provided a presentation which I'm going to start now. Hopefully the sound should come through and we won't have any more technical issues. So I'm going to start from the beginning with the slideshow and it should come through to you as of now. Ava, if you just type in the box, please, to let me know. And thank you very much for your patience, and Ava for helping out, and David for your patience. Thank you.
Good afternoon. My name is David Shelton. I'm one of the consultant cytopathologists at Manchester Cytology Centre, and I'm going to talk this afternoon about salivary gland cytopathology. With FNAs, the purpose of salivary gland FNA is to provide the clinical team with a risk stratification tool that will allow them to determine the extent of treatment the patient requires for their salivary gland lump. So that can identify cases that require surgery and help the clinical decision-making process as to the extent of the surgery that is required, i.e. partial versus complete prostatectomy, plus or minus neck dissections. If possible, we will provide a specific diagnosis, but as we'll discuss later, that is not always possible with salivary gland cytopathology. In general, the performance of salivary gland FNA is very good, and you can see there the sensitivity and the specificity for malignancy. Salivary gland cytopathology, however, can be challenging, and here are some of the common challenges we face with regards to false positive and false negative for malignancy within FNAs. The purpose of salivary gland FNA is to provide the clinical team with a risk stratification tool that will allow them to determine the extent of treatment the patient requires for their salivary gland lump. So that can identify cases that require surgery and help the clinical decision-making process as to the extent of the surgery that is required, i.e. partial versus complete prostatectomy, plus or minus neck dissections. If possible, we will provide a specific diagnosis, but as we'll discuss later, that is not always possible with salivary gland cytopathology. In general, the performance of salivary gland FNA is very good, and you can see there the sensitivity and the specificity for malignancy. Salivary gland cytopathology, however, can be challenging, and this is because there are over 35 different salivary gland epithelial tumours which show significant morphological overlap. Within the salivary gland, low-grade malignancy can appear morphologically bland and result in false negative diagnoses. Here are some of the common challenges we face with regards to false positive and false negative for malignancy within the salivary gland, and we'll go on to discuss some of these later on in the presentation. with the aim to standardise reporting of salivary gland FNAs and aid communication of the results to the clinical teams. The Milan system for salivary gland cytopathology was published in 2018. Here's a nice table demonstrating some of the uses of each of the categories, and we'll go on to discuss these shortly. Here's a publication from 2023 from a large series of cases that demonstrates their risk of malignancy and percentage use of each of the Milan categories, with also a review of the literature. So this can be helpful as a benchmark for audit of local practice. Although, as I mentioned, ideally, each department would have their own established risks of malignancy and percentage use of each of the categories. Moving on to the cytology of salivary gland FNAs. So normal salivary gland samples would be composed of acinar cells and ductal epithelial cells, with or without fibroadipose tissue. If we receive an FNA sample from a salivary gland and all we have is normal salivary gland constituents, we need to ask ourselves whether or not this is representative of the lesion, especially in the context of a radiological mass. Context of normal salivary gland sampling, most of the epithelial cells would be acinar cells, which would appear as cohesive grape-like clusters with round eccentric nuclei, small nucleoli, and granular cytoplasm. And we can sometimes see the preserved architecture within some of the groups. And here we can see the grape-like acinar cells with some ductal epithelial cells and capillaries transgressing through the groups. Ductal cells would represent a smaller proportion of the epithelial cells present in normal salivary gland, and they appear on cytology as honeycomb fragments of low cuboidal to columnar epithelium. They can undergo squamoid or oncocytic metaplasia, which can cause confusion. So if all we receive is normal salivary gland constituents, the question to ask is this representative of the lesion? Most often, these will be reported as inadequate or non-diagnostic and Milan category 1. Occasionally, normal salivary glands will be targeted for FNA for confirmation they are actually salivary glands or potentially accessory salivary glands. And so if we receive normal salivary gland constituents in this scenario, it would be categorized as Milan 2, non-neoplastic. In reporting salivary gland FNAs, I like to consider a pattern-based approach, with each of the patterns having an associated differential diagnosis. And we'll discuss these categories in turn now. So the first pattern is the inflammatory pattern. And here are some of the differential diagnoses that we can consider on the inflammatory pattern. And I won't discuss all of them, just the ones that are more problematic for cytology. First is chronic sialadenitis. This is typically a scanty aspirate and is predominantly composed of ductal epithelial cells with a paucity of acinar cells, which we would typically see in normal salivary gland sampling. The ductal cells can undergo metaplasia, which can cause problems, and there will generally be background inflammatory cells and debris. There can be cystic change with mucin, which can cause problems, distinguishing from mucoepidermoid carcinoma. But generally, the typical features of ductal epithelial cells and background inflammatory cells can lead us to the correct diagnosis. The pitfalls here is that given the paucity of the epithelial components in the samples, they are often inadequate. And conversely, if we see ductal epithelial cells that appear basiloid in the context of chronic sialadenitis, we can overcall the samples as a basiloid neoplasm. The next problematic diagnosis in salivary gland FNAs is lymphoepithelial ciliadenitis. So this typically affects middle-aged to elderly women and is of autoimmune origin associated with Sjögren's syndrome. The salivary glands can be affected bilaterally and symmetrically. On the aspirate, we will see polymorphous reactive lymphoid cells with plasma cells and histiocytes. The epithelial cells will percolate through the epithelial groups, forming lymphoepithelial lesions. The pitfall here is, especially in the context of Sjögren's syndrome, these patients are at a significantly increased risk of low-grade B-cell non-Hodgkin lymphomas, and morphologically, these can be indistinguishable from lymphoepithelial ciliadenitis. So if that is a concern, then flow cytometry, and you have it available, and flow cytometry could be performed to determine whether there is clonality within the lymphocytes. And here we can see a mixture of polymorphous lymphocytes with some histiocytes and some possible epithelial cells. So often these would be categorized as Milan 2, non-neoplastic. However, if there is a concern for low-grade non-Hodgkin lymphoma, and we don't have flow cytometry to assess further, they can be placed in the Milan category 3, atypia of undetermined significance category, with the advice to the clinical teams to either repeat the FNA for flow cytometry if available, or for core biopsy for further assessment. Moving on to lymphoma, which would also fall within the inflammatory pattern. The three most common types of lymphoma that would be identified within the salivary glands are the extranodal marginal zone lymphomas, follicular lymphoma, and diffuse large B-cell lymphoma. So the main problems that we will face on cytology is with the two low-grade B-cell non-Hodgkin lymphomas, extranodal marginal zone lymphoma versus follicular lymphoma, as there's a risk of false negative diagnosis here. Extranodal marginal zone lymphoma is indistinguishable from lymphoepithelial ciliadenitis on morphology, and ideally, as I said previously, we need flow cytometry to make this diagnosis. Here's an example of a diffuse large B-cell lymphoma. And as you can see on the morphology, you have The next problematic diagnosis in salivary gland FNAs is lymphoepithelial ciliadenitis. So this typically affects middle-aged to elderly women and is of autoimmune origin associated with Sjögren's syndrome. The salivary glands can be affected bilaterally and symmetrically. On the aspirate, we will see polymorphous reactive lymphoid cells with plasma cells and histiocytes. The epithelial cells will percolate through the epithelial groups, forming lymphoepithelial lesions. The pitfall here is, especially in the context of Sjögren's syndrome, these patients are at a significantly increased risk of uh, low-grade B-cell non-Hodgkin lymphomas, and morphologically, these can be indistinguishable from lymphoepithelial ciliadenitis. So if that is a concern, then flow cytometry, and you have it available, then flow cytometry could be performed to determine whether there is clonality within the lymphocytes. And here we can see a mixture of polymorphous lymphocytes with some histiocytes and some possible epithelial cells. So often these would be categorized as Milan 2, non-neoplastic. However, if there is a concern for low-grade non-Hodgkin lymphoma, and we don't have flow cytometry to assess further, they can be placed in the Milan category 3, atypia of undetermined significance category, with the advice to the clinical teams to either repeat the FNA for flow cytometry if available, or for core biopsy for further assessment. Moving on to lymphoma, which would also fall within the inflammatory pattern. The three most common types of lymphoma that would be identified within the salivary glands are the extranodal marginal zone lymphomas, follicular lymphoma, and diffuse large B-cell lymphoma. So the main problems that we will face on cytology is with the two low-grade B-cell non-Hodgkin lymphomas, extranodal marginal zone lymphoma versus follicular lymphoma, as there's a risk of false negative diagnosis here. Extranodal marginal zone lymphoma is indistinguishable from lymphoepithelial ciliadenitis on morphology, and ideally, as I said previously, we need flow cytometry to make this diagnosis.
It's just
Lymphoma taken from the salivary gland. So here we have a monotonous population of these small lymphoid cells, just slightly larger than the red blood cells, some of which have a plasmacytoid morphology. The monotony is the clue here that this is neoplastic. However, they don't always look like this. There can be polymorphism within the sample, even with even with tingible body macrophages within the background. So ideally, flow cytometry or histology is recommended in these cases. Moving on to the matrix producing pattern. So these are the FNAs of salivary gland lesions that contain matrix. And these will often overlap with the basaloid type pattern. And we'll discuss some of these ones now, the common ones and some of the problematic ones as we go forward. So pleomorphic adenoma is the commonest salivary gland neoplasm, accounting for 60% of the neoplasms, and thankfully it is recognizable on salivary gland FNA. It is most common in the parotid and has a wide age range of patients. So as we know, the characteristic feature of pleomorphic adenomas on cytology is the abundant metachromatic fibrillary matrix, and we can spot embedded epithelial and myoepithelial cells within the matrix. This is highly specific for pleomorphic adenoma. The most common problem we face with pleomorphic adenoma on cytology is when there is a paucity of matrix material, and often we can't establish a confident diagnosis in those cases, and they're often categorized as salivary gland neoplasm of uncertain malignant potential. If we have PLAG1 IHC, this can help, but often the labs, at least in the UK, don't have this immunostain. And here we have on the MGG stain lots of fibrillary feathery matrix material at low power. We can see these plasmacytoid myoepithelial cells embedded as single cells within the matrix material. Very wispy, edged material. And again, myoepithelial cells embedded with the matrix material going all around the myoepithelial cells. On the pap stain, this appears more greyish blue, wispy pattern, no hard edge to the matrix material, and the matrix going all around the epithelial and myoepithelials. We compare this to adenoid cystic carcinoma, which is also another matrix-producing tumour. These tumours are more common in the minor salivary glands, in the middle-aged elderly people. We have 3 patterns on histology, but on cytology, typically we will see basaloid cells with angulated crowded nuclei, and hopefully the characteristic matrix material, which is in globules or tubules with very hard-edged matrix, and we'll see some more pictures in a second. These tumours have a MIB fusion, so if it's available, FISH can confirm the diagnosis on the cytological diagnosis. Here we have the typical basaloid epithelial cells, and they're surrounding the hard-edged, dense matrix material, which here is in a globule. On the pap stains, again, we can see this cribriform pattern with the basaloid angulated epithelial cells and this hard-edged matrix material. Sometimes the matrix can be more in tubules and it can mimic pleomorphic adenoma, which is why the PLAG1 and the MIB FISH can help with the diagnosis. Again, there's a tubular type matrix material here, very hard edged, with the basaloid epithelial cells arranged around it. There's quite little scanty matrix material here, so a proportion of the adenoid cystic carcinomas would be placed in the salivary gland neoplasm of uncertain malignant potential category rather than the malignant category if we can't make the definite diagnosis. Here's an example of the histological section of an adenoid cystic carcinoma showing similar features. This pattern is the basaloid pattern, which, as I say, overlaps with the matrix-producing pattern, and the differential diagnosis would include similar entities within both of those categories. Adenoma is a rare benign tumour, which on cytology appears as has a similar morphology to other basaloid type neoplasms and is indistinguishable on cytomorphology. Typically, these appear as geographic cohesive groups of basaloid epithelial cells, and clues to the diagnosis can be a rim of matrix-like material surrounding those geographic groups, and we'll see a picture of that in a second. The pitfall here is on cytology is between adenoid cystic carcinoma, basal cell adenocarcinoma, which is indistinguishable on cytology. And as I mentioned, we can overcall chronic style adenitis as basal cell neoplasm. As an example of a basal cell adenoma on cytology, and you have these cohesive groups of basaloid epithelial cells with very high NC ratio, angulated nuclei. On morphology, this would be indistinguishable from adenoid cystic carcinoma, and we would place this in the 4B salivary gland neoplasm of uncertain malignant potential category under Milan. As an example on the pap stain, and you can see the rim basement membrane like matrix material going around this group, which would be a clue to the diagnosis. Moving on to the oncocytic and clear cell pattern. So the main differential diagnoses here will be between Warthin's tumour, metastatic carcinomas, and actinic cell carcinoma, and we'll discuss these in turn. The Warthin tumour is a common benign neoplasm, most commonly affecting men, middle-aged smokers. They can be bilateral. On cytology, we'll have a trilogy of oncocytes, lymphocytes, and background proteinaceous material. The oncocytes will be in flat honeycomb sheets with round nuclei usually containing nucleoli and granular cytoplasm. Can see corporate amylasia there too, and crystalloid material. So there are a few pitfalls here. Warthin's tumours themselves can undergo metaplasia, including mucinous metaplasia, which can lead to confusion between mucoepidermoid carcinoma. But conversely, there's a risk of false negative diagnosis, i.e. we undercall a malignancy as a Warthin tumour. And the main ones here will be mucoepidermoid carcinoma can have cells that appear oncocytic, and so there's a risk of a false negative diagnosis if we interpret those as oncocytes. So careful consideration for mucin in the background, as well as the mucinous cells, and also take into consideration the patient demographics. So Warthin's tumours, very rare in young people and in locations outside of the parotid. Other tumours that can mimic Warthin's tumour could even be metastatic papillary thyroid carcinoma, can be undercalled as a Warthin tumour, as the PTC cells have that granular cytoplasm with the background lymphocytes and cystic change. So here we have sheets of oncocytes with background small lymphocytes. The oncocytes are in a nice flat sheet, fairly uniform nuclei with small lymphocytes scattered throughout the background. We get the hint in the background here that there's some granular material, cyst contents. On the pap stain, we'll see that characteristic granular cytoplasm. Here's a Warthin's tumour on histology showing that those three components of oncocytes, lymphocytes, and cystic background. Being a benign neoplasm, Warthin's tumour would be categorised under the Milan 4A category, which is neoplastic benign. So moving on to actinic cell carcinoma, this typically affects the parotid gland and has a very wide age range of patients, ranging from 20 to 70 years. This is a common cause for false negative diagnoses in salivary gland cytopathology because it has a diverse cytomorphological appearance and varied architectural appearance on cytology. So typically the samples are cellular and will have disordered sheet papilloid clusters and groups of cells that resemble acinar cells. There are typically transgressing capillaries through the groups, and the epithelial cells appear bland with prominent nucleoli, and they can have intranuclear inclusions. If on the direct spread preparations, the nuclei can be stripped from the cytoplasm and resemble lymphocytes, be mistaken for lymphocytes. So again, this can be undercalled as Warthin's tumor, as people interpret the acinic cell carcinoma cells as oncocytes with background lymphocytes. If it's available, the immunocytochemical stain DOG1 is diagnostic for the acinic cell carcinoma. We need to consider differential diagnoses. So metastatic renal cell carcinoma will resemble acinic cell carcinoma, and again we can perform immunocytochemistry if available. A PAX8 stain would be positive in metastatic renal cell carcinoma but negative in acinic cell carcinoma. Other clear cell neoplasms such as secretory carcinoma would be in the differential diagnosis, although would receive the same treatment as acinic cell carcinoma, so potentially the specific diagnosis is not so important there, as the patient would receive the appropriate treatment. And they have a typical rearrangement, which is stated there. Here we can see the neoplastic cells with round to ovoid nuclei, prominent nucleoli, and this abundant granular to clear cytoplasm. And here we can see the papilloid groups of the atypical epithelial cells that do appear relatively bland, round nuclei with prominent nucleoli, and we have transgressing capillaries running through the groups. This is a picture of acinic cell carcinoma showing the typical cytomorphological features resembling benign acinar cells, but the architecture is wrong for that. It is on a histological sample. Then we have the cystic pattern. So many neoplasms can be cystic. However, the one of the main diagnostic dilemmas we'll face in salivary gland cytology with regards to cysts is the mucinous cysts. And the differential diagnosis is between the non-neoplastic mucocele and low-grade mucoepidermoid carcinoma. Mucocele or retention cyst, these are caused by disruption of the salivary ducts, resulting in extravasation of mucin with surrounding inflammation. Typically affects the minor salivary glands, and on cytology we will often see abundant mucin with some macrophages and scattered inflammatory cells. Occasionally we may see ciliated epithelial cells arising from the ducts, which can be helpful to make the diagnosis, but typically they have few epithelial cells. And as the pitfall and the differential diagnosis is still between mucoepidermoid carcinoma, typically these are placed in the atypia of undetermined significance category on the Milan, i.e. Milan 3 category. Lots of extracellular mucin with scattered inflammatory cells. And here on the PAP, we can see this wispy mucin material. Sometimes we may have an element of chronic sialadenitis, which can help with the diagnosis. Mucoepidermoid carcinoma is the most common salivary gland malignancy. And in contrast to the mucocele, which typically affects the minor salivary glands, mucoepidermal carcinoma will affect the parotid approximately equally to the minor salivary glands. On cytology, we see a combination of mucus cells, intermediate cells, and squamoid cells. The samples are often variably cellular and sometimes can be acellular, hence the use for the atypical of undetermined significance category for those samples. There generally is background mucin, which appears dirty with necrotic or granular debris, with groups of the epithelial cells dispersed throughout. The tumours typically show mammal 2 rearrangement, which can be identified on fish, which can be helpful if it's available. You can see some wispy extracellular mucin with scattered macrophages and some inflammatory cells. Got a disordered group of mucus cells. We can see some cytoplasmic vacuolation with these prominent cytoplasmic membranes, although they do appear relatively bland on morphology. Groups of epithelial cells appear more intermediate, cohesive, overlapping, crowded groups. And here we have an example of the sort of granular necrotic background that we can sometimes see with mucoepidermoid carcinoma. Cells appear more squamoid with this dense glassy cytoplasm and centrally located nuclei, again with a necrotic, dirty background. The mucin can also appear colloidal, as in this, with this dense, hard-edged to the extracellular mucin. Example on histology. Finally, we have the high-grade malignant pattern of salivary gland cytology. So here the main differential diagnosis is between primary high-grade salivary gland malignancies versus metastasis versus lymphoma. And often we can't subtype the high-grade primary salivary gland malignancies on cytology, as these require histological analysis on the resection. But thankfully, the clinical management is usually not affected by this, as they will receive the same treatment, which would be more extensive and potentially radical surgery. So I'll briefly discuss 2 of the primary high-grade salivary gland malignancies on cytology. The first one is carcinoma ex pleomorphic adenoma. This results from malignant transformation in a pre-existing pleomorphic adenoma, typically in older people, and the cells on the sample will appear frankly malignant and high grade. The only clues to the diagnosis can be either a clinical description of a pre-existing pleomorphic adenoma with sudden rapid increase in size, or occasionally we may see a mixture of the benign pleomorphic adenoma and high-grade malignant component within the same sample. Features of other salivary gland malignancies can also be present, which can confuse the diagnosis. Example of carcinoma ex pleomorphic adenoma, you have large, highly atypical cells, prominent nucleoli, and moderate amounts of cytoplasm. So it's high-grade malignant, although on the morphology, we don't have any clue as to what the subtype, what the tumor type is. Again, high-grade malignant sample, very large cell with prominent nucleoli. We may see resemblance of matrix material in carcinoma ex pleomorphic adenoma, although it can be challenging to distinguish this from desmoplastic stromal fragments on the sample. Second example is a salivary duct carcinoma. These are clinically aggressive, usually in elderly men in the parotid. Again, on cytology, the cells are obviously malignant and high grade, although often we cannot reliably subtype the high grade malignant tumor. So high-grade tumours often appear as poorly differentiated carcinoma, not other specified, with no clear evidence of subtype on cytology, but it was more important to distinguish high-grade carcinoma from low-grade carcinoma than to accurately subtype the tumour, as this will determine the patient's treatment pathway.
Okay, I'm just checking that people can see me. I have stopped the share, but I can't see myself. Yes, okay. Thank you very much, David. That was a really excellent talk, and that PowerPoint, not the recording from this session may be a bit clunky because of all the technical problems, but the PowerPoint itself can be emailed out to all the attendees. Are there any questions for Dave in the chat? He seems to have a problem with connecting with audio. Any questions? I mean, it's a really comprehensive run through of cytopathology of the salivary gland. I learned a lot. I think if you took everything from that talk, you'd be able to cover the vast majority of salivary gland cytology, I would think. Any questions? Okay, I think David, you've stunned them into silence. I don't know if Noreen is going to be joining us today. Noreen Akhtar had planned to join as a second speaker today. We have actually come up to the hour. I don't know if Noreen is still has joined or is going to be able to present today, or maybe, I don't know, and this is presumptuous of me, but maybe Noreen could present next week or at another time instead, because I know that she has prepared cases, and that may also give us time to follow up with David any problems. David, don't you apologise for technical problems at all. It's a combination. Sometimes the way people log in or the configuration of the machines on different platforms, either Zoom or Teams or this webinar kit, can affect things. So we have to bear with that. But I'm very sorry that you've come across problems we've not come across before. It's a learning experience for us too. But the most important thing is the presentation seems to have gone out. And we can also, and because you've really kindly recorded it in advance, we can send it out to people by email as well. So have we, Ava, are you still there?
Yes.
Okay, so David, I don't know if you're able to put in the chat, I don't know if Noreen is planning on joining us today, or shall we reschedule Noreen's session? I know that's maybe irritating for Noreen, but it might give a better time with the audience. I don't know if Noreen is on the line. Okay, thank you. If she could do it another time, that would probably be better for the audience and maybe for her as well. But of course, she was scheduled. I don't want to interrupt her afternoon any further, is what I'm saying. Also, just a question while you're on the line, Ava. There's a doctor who tried to join from Lesotho and wasn't able to get in using the registration link that you WhatsApped me, then I forwarded on to them. I don't know if there's any territorial problems that you've encountered.
I'm not sure. That might be the issue.
Okay. Well, what I've done is I've asked the doctor to send me his email, and I'll pass it on to you so that then we can pass the thing through to that person as well.
Okay.
So it looks like we're going to reschedule Dr. Akhtar's presentation. Hopefully that could be next week, but I will let everyone know. So next week at the normal time, it'll either be myself doing hematopathology or possibly hi, this is Noreen. Hi, Noreen. It's very difficult doing everything through chat. I don't know if you're able to do 1 p.m. next Wednesday instead. Oh, you got the invite from 2 p.m. Okay. You can do 1 p.m. next Wednesday. That would be, I don't know which date that would be, the 10th. Next Wednesday, perfect. That would be really good because I'm actually in London, so that makes it a little easier for me as well. And what we'll do is, so we're going to have more cytopathology next Wednesday. And what we'll do is I will do a test session. So Ava, if you can just resend the invite to Noreen to make sure she's got it for 1 p.m. GMT next week.
Yes, I can do that.
And maybe what we'll do is, if you send the same invite to both of us for, say, Tuesday, let me just look at my calendar. Tuesday next week. Noreen, what time is good for you Tuesday next week in the afternoon? From, say, let's see, say from, say at 2 o'clock. Would you be free at 2 o'clock for 10 minutes next Tuesday for a test? Yeah, okay. So Noreen, so Ava, I'm sorry about this. Very difficult. Everything's spinning around on my. I've got this thing which keeps on going round and round on my computer. So if you send the invite for us to do the talk at 1 p.m. next Wednesday, but a 10-minute or 15-minute test at 2 p.m. Next Tuesday. So we've got it all lined up. That would be helpful, very helpful as well.
Yes, definitely. And I'll check my calendar, but worst case, if I have a call, you have the login to do that.
Okay, for sure. And will you put it down as a new one, Ava, Richard, and Noreen test? So I'm in the right test environment. Great. Okay. And that would obviously be a different would that be a different ID then for the Wednesday one?
Yeah, since it would be a test.
A test ID. So Noreen, the ID that you get for Tuesday, the webinar kit ID you get from the Tuesday will be a different one for the Wednesday. So whatever for Wednesday, so Wednesday, log in on the Wednesday webinar kit ID link and not the one from Tuesday. They'll be take you to slightly different webinar rooms. Okay. Thank you very much, everyone, for your kind attention. A technically difficult day, but we will persist no matter what the difficulties, and I hope that was useful. Of course, the presentation, which is an excellent presentation, one of the best I've seen, actually, David. Absolutely one of the best I've seen. Will be going out to everyone. We'll have to work out a way of sending it, given its file size, which just looking at it now, it's quite large. But we'll cross that bridge when we come to it. Myself and Ava will work on a way of sending it through. Maybe it has to go in a Google Drive with a link to it. Okay, so without further ado then, as we're over the time, I don't know if anyone's got any other further comments, either David or Noreen or Ava, before we go.
No, I'm all set. Thank you.
Okay, and thank you for the others. So in the words of a very famous British television series of days gone by, it's goodbye from me and it's goodbye from them. So thank you very much. Bye-bye.